All right, so she is a 33-year-old female, was pretty healthy until about 2 years ago when she first came to medical attention for hypothyroidism. And then over the last couple of years has kind of accumulated a number of medical comorbidities, including pulmonary hypertension, syncope, pretty severe peripheral neuropathy, kind of axillary adenopathy, MGUS, anemia, as well as thrombocytosis. So on the 11th of this month, she was admitted to the gyn-onc service from clinic for kind of expedited workup of uterine fibroids. And in her admission H&P, review assistance was significant, pretty pan-positive, but notable for significant dyspnea, leg swelling, severe peripheral neuropathy, to the extent that she has to use a wheelchair for the last month or so. Chest pain, 50-pound weight loss, significant abdominal distension, and amenorrhea. So after she was admitted, she got a number of labs for workup, and I've just highlighted a few here. Notable are the free kappa and lambda light chain values, as well as the IFE, which showed IgA monoclonal expansion and a markedly elevated VEGF at 11,887. Additional workup that she had done here in the hospital included an axillary lymph node biopsy, and that just showed basically some dermatopathic changes, but no granulomas, no metastatic tumors. CT of abdomen and pelvis showed a large pelvic mass measuring up to 11.8 by 10.2 centimeters attached to the uterus, and as well as some abdominal retroperitoneal and pelvic adenopathy and some splenomegaly as well. On bone marrow biopsy on the 16th, that was notable for some plasma cell neoplasia with 20 to 30% plasma cells and a 75% cellular marrow. And then on the 18th, she was transferred to our hematologic malignancy service for additional workup and management. And at that time, the differential for her included plasma cell dyscrasia, possible Poland syndrome, primary amyloidosis, non-secretory myeloma, and CIDP. So that's where we got involved. The 9100 service consulted us, and basically their consult question was, can you help us distinguish between amyloidosis and Poland syndrome? And as a brief reminder, Poland syndrome it's an acronym that stands for polyneuropathy, organomegaly, endocrinopathy, and protein spike, as well as skin changes. And that just highlights a few of the key features of Poland syndrome, which we'll go over in a few minutes here. All right, so when we went to go see her on her general exam, she was very cachectic, but doing okay, working pretty hard to breathe. And then her extremities were notable for some peripheral edema and some clubbing of the fingers. Her neuro exam was notable for some decreased strength pretty significantly in her distal lower extremities, but relatively preserved in the uppers. Sensation was significantly diminished to vibration and proprioception. Temperature was decreased as well, but pinprick was pretty preserved in the bilateral lower extremities. Reflexes were down throughout, completely absent in the lower extremities, and then 1+ in the uppers. And at that time, she was able to ambulate, but she noted kind of bilateral foot drop that made it difficult, and she needed to use an assistive device or watch her feet as they were going to make sure that they were going in the right place. She had to get an inpatient EMG nerve conduction study, and that was notable for length-dependent subacute to chronic demyelinating sensory motor polyneuropathy with secondary axonal loss, which they interpreted as being consistent with Poland syndrome. And then a few things to note in the results and interpretation of that is that the absent sural nerve response argued against a CIDP picture. The demyelinating feature that was found on EMG nerve conduction study was more consistent with POEMs, whereas amyloidosis would be more of an axonal sensory motor neuropathy. So that kind of helped us differentiate that question that they had for our consult team. Also noted was no conduction block, which would be seen with CIDP, and they noted relatively symmetric changes between her bilateral lower extremities. So going over the criteria for Poem syndrome, basically a person needs to meet both of the mandatory major criteria, that gray box at the top, and one of the other major criteria, as well as one of the minor criteria in that gray box in the middle. And so looking at the patient that we saw, she certainly met all of the necessary criteria for Poem syndrome, had pretty severe demyelinating polyneuropathy, had the monoclonal plasma cell dyscrasia, Castleman disease. For those of you who need a little refresher like I did, is basically an angiopoietin dysplasia, basically a finding that can be found on the pathology of a lymph node. This patient had a markedly elevated VEGF, and then she met almost all of the minor criteria as well over here, as you can see. Also had the other symptoms and signs of weight loss, pulmonary hypertension, which was pretty significant and profoundly bothersome for her, given her shortness of breath. And then PFT showed a severe restrictive lung disease with like 40% expected pulmonary capacity. All right, so thinking about the different options we have for treatment of Poem syndrome, usually from what I could read, the first step in therapy is radiation, particularly if they've got focal bone lesions or sclerotic bone lesions. More systemic, they'll go with more systemic therapies, including steroids and then combinations of chemotherapies. And then for relatively young and healthy individuals, stem cell transplant, autologous stem cell transplant was found to be pretty effective, but clearly that carries a significant morbidity. And then with the treatment options down here at the bottom, they were found to be relatively effective, but had the side effect of peripheral neuropathy, potentially worsening peripheral neuropathy, which for many of these people with Poem syndrome is a very significant feature of their disease, and certainly don't want to exacerbate it with the therapy we're trying to use. And then the patient that we had while she was here, she was started on a 4-day burst of corticosteroids. And then I'm not sure exactly what the outpatient treatment plan would be for her, but I imagine she would probably be proceeding with some radiation as an outpatient. So a few take-home points that I wanted to highlight. I know we see peripheral neuropathy all the time in our clinics, at least we do in the resident clinic. So if we have a CIDP-like syndrome, don't wait until they fail CIDP treatment to consider checking VEGF and getting them started on Poem syndrome treatment. And then a note to our stroke specialists out there, given their significant hematologic abnormalities, they can sometimes present with arterial or venous clots. So in someone with a severe peripheral neuropathy, that's something to keep in mind on your differential. And then as far as treatment is concerned, the neuropathy does tend to improve, but it takes about 3 to 6 months on the therapy before you see any improvement in those symptoms. So that's kind of one thing to help guide patients on and kind of manage expectations there. And then unfortunately untreated, the natural progression of Poems is significant and severe peripheral neuropathy until the patient becomes bedridden and succumbs to an infection or a cardiac disease of some sort. All right, and thank you for your attention. And I will send it back to our Grand Rounds presenters.
Thank you.
Today.
Thank you very much, Amanda. So today's Grand Rounds is sponsored by the Movement Disorders Division, and it's a combo of Noreen Bukhari-Palarchuk and Bryan Howell. So Noreen, I'll turn it over to you.
Thank you so much. Can you hear me okay?
Yep.
Great. Good morning, everyone. I'm very excited to give this talk today. I presented last time at Grand Rounds 2 years ago, so I believe we have made some progress that I'm happy to share. We decided to do something different today. In addition to giving a perspective on the future of neuromodulation, non-invasive neuromodulation from my team's perspective and a neurological perspective, we decided to add on the perspective of an biomedical engineering group. Specifically, Bryan Howell is an assistant professor working with Dr. Cameron McIntyre, who recently arrived here at Duke University. We're very fortunate because Dr. McIntyre has been doing these exciting and cutting-edge state-of-the-art work in deep brain stimulation, and Bryan has been working with him, but he's also started to branch out and develop a transcranial electrical stimulation and explore it as a home-based stimulator for Parkinson's disease. So we're excited to hear his work. I will say Bryan is not a stranger to Duke University. He actually did his PhD in biomedical engineering here. So let me begin first by discussing a little bit about movement disorders in general, and then the work that my team has done and where we hope the future will be with our work. So movement disorders, as many of you know, are a group of neurological disorders that comprise of either let me just make sure I have, group of neurological disorders that comprise of either a paucity of normal movements or there is an excess of involuntary movements. Now, there are quite a number of movement disorders. For the purpose of today's talk, I will focus on 4, which are Parkinson's disease, Huntington's, dystonia, and Tourette's. They present with different movement disorder manifestations, but what is common to all of them is that there is no disease-modifying treatments for any of these movement disorders. And symptomatic treatments in the form of medications and botulinum toxin actually have limited benefit because they actually can provide symptomatic treatment, and then they actually vary in terms of efficacy. The symptomatic treatments vary in efficacy from patient to patient. So really, we do need better treatment options for our patients in movement disorders. Now, in a subset of these patients, we actually do have an invasive brain procedure called deep brain stimulation, which is an option. Deep brain stimulation is an invasive brain stimulation technology. It involves an electrode that is implanted into the brain and emits focal electricity in the deep brain region, which can then allow for symptomatic treatment of these patients. Now, DBS is actually FDA approved in Parkinson's disease and in essential tremor. It is a humanitarian clause for use in dystonia, and it's currently under study in Tourette's syndrome. Now, DBS for the subset of patients who qualify is actually very effective. It really does improve their quality of life significantly. But as I said, it is a surgery, and so it comes with surgical risk, and so we have to be very carefully weighing the risks and benefits when we decide who qualifies for DBS. Beyond just the surgical risk, we also have the side effect concerns that long-term these patients can go on to develop memory impairment, dysarthria, dysphagia, or gait instability. And so, unfortunately, this invasive brain stimulation technology is not available to majority of our patients. Having said that, transcranial magnetic stimulation, this is a non-invasive stimulation technology. TMS involves an electromagnetic coil that is applied to the scalp, and it emits, when TMS is applied to the scalp, it actually induces current in the cortical region immediately adjacent to it. And depending on the dosage of stimulation, this can lead to depolarization or hyperpolarization of the cortical neurons. So TMS is actually FDA approved in clinical treatment of depression, obsessive compulsive disorder, migraine, and chronic pain. It's currently being studied as a treatment option for Parkinson's disease, Huntington's, dystonia, and Tourette's. And I've listed the number of studies that are ongoing or have been completed in this area. And in these studies that have been completed, we actually have seen transient clinical benefit. So can you imagine a future where TMS could actually, as a non-invasive brain stimulation technology, provide focal brain stimulation and thereby potentially transform the way we do neuromodulation therapy? So TMS is currently being studied as an option in terms of a non-invasive brain stimulation that can deeply target the brain. And specifically, there's an emerging group of evidence that when you combine TMS with functional neuroimaging like functional MRI, you can actually stimulate subcortical brain networks and improve behavior. I'm going to give you 2 examples of that. This was an early study that showed that if we target the cortical region, and here they were targeting the parietal, they could actually affect deep brain region of hippocampus. And by targeting sort of a brain connectivity approach, they were actually able to show a change in functional brain connectivity as well as an improvement in behavior. And so that was very powerful to say that TMS can actually modulate not only the superficial cortex, which is what the technical limitations are, but it can actually go beyond that superficial cortex by using functional brain network information to be able to target deep brain circuitry. Another group actually used the same approach in the treatment of depression. And what they did is they were trying to target the subgenual cingulate cortex, which is a much deeper cortical region. And they used the knowledge of functional connectivity between the subgenual cingulate cortex and the dorsolateral prefrontal cortex. And they were able to show that using knowledge of functional connectivity, they were able to target and modulate this as well as behavioral changes in depression. And so TMS therefore becomes a really powerful approach if we can have potentially develop this as a technology to non-invasively modulate deep brain circuitry. Now, there's 2 important aspects of that. There's the non-invasive nature, which then allows this to be open to multiple different, to a larger group of patients with movement disorders. So we no longer have to worry about surgical implantation and the risks of that. But then also we have this ability to specifically and selectively target a circuit. And so that would be also change the way we approach neuromodulation therapy. It's possible, and again, these is all about possibilities. It is possible that when we target with a circuit selective way, we could actually be doing more than just symptomatic therapy. We could potentially be affecting long-lasting disease modifying therapy. And so to begin with that, now TMS has actually been studied also in Parkinson's and studied in terms of determining how we can target deep brain circuitry. So repetitive TMS was applied at the motor cortex in Parkinson's disease patients and the hemi-Parkinson's patients. And what they found is actually using a PET scan, they were able to see select dopamine release in the striatum of these patients, albeit it was larger amount of dopamine release in the asymptomatic side compared to the symptomatic side. And so that was an opening to say, well, we actually do have that potential even in disease patients, not just in normal patients, but in disease patients, we have the ability to use TMS to modulate deep brain circuitry. And so this sort of began where I started my research, asking the question that can we use TMS to target deep brain circuitry? And specifically, what I was really interested in knowing is, well, what is the best region to target in the cortex that could then affect deep brain circuitry? And what is the deep brain circuit network that we care about most in movement disorders? I think knowing a knowledge of general movement disorders, we do have some inkling that the corticostriatal circuit may be an important one because it is commonly known to be abnormal in all movement disorders. However, having said that, we started sort of in an unbiased way, and we started to explore this question. In order to study this, I specifically focused on one type of movement disorder called dystonia. And so I'm showing an image here of a generalized dystonia, but we actually decided to focus on a subset of dystonias called the focal hand dystonia patients that is more common in the adult population. And specifically, patients develop these abnormal postures that interfere with writing and performing movements. And it's a task specific, so it occurs during the task of writing. And so we decided to use writer's cramp dystonia as a research model to study the brain networks of dystonia patients. And we began by asking the question, what is the abnormal brain network during the dystonic task? So we had patients perform simple writing tasks in the functional MRI, and we also had them perform a sequence tapping task, as well as opening and closing of their hand, finger flexion and extension. We were able to complete this in 12 writer's cramp and 12 healthy subjects. And then we performed a group independent component analysis asking what are the changes that are happening across all three tasks and what is specific to the writing task to help us distinguish what is happening in the writing task and how that differs between healthy and dystonia patients. And so we identified 8 functional brain networks that were important and of interest to us, including the left sensory motor. These patients actually perform their task with their right hand, and they are dystonic in the right hand. And so we expect the left sensory motor to be an important region in this pathway. We also identified the visual, the cerebellum, the basal ganglia, and some additional networks, including the default mode network, which is known to be important during rest. And so the first thing we did is we actually looked at how these different networks, how these 8 networks correlate with the writing task. And what I'm showing you here is the sort of organized from highest correlation to lowest correlation. And we are comparing healthy subjects in blue and writer's cramp in pinkish red. And what we see is that left sensory motor cortex has very little variability and the strongest correlation, which is what we expect with a motor task. And as we go across, we actually see that the circuit that is most abnormal and showed statistical difference for us was the basal ganglia. So patients with writer's cramp showed decreased correlation with writing in the basal ganglia compared to healthy subjects. Now, what's interesting is that the other 2 motor tasks did not show this type of difference, suggesting that there's something unique happening with the basal ganglia in writer's cramp subjects. And so we then asked, what are the changes in functional connectivity that are happening irrespective of the task in writer's cramp? And so across the 8 functional networks, we actually did comparison to itself and to other brain networks to ask what are the changes in functional connectivity. And so this is a functional connectivity matrix that you're seeing with yellow showing the highest correlation and blue showing the weakest correlations. And so we looked at this functional connectivity matrix across healthy subjects, dystonia subjects, and then we asked what is statistically different between the 2 groups. And we looked at it across all 3 motor tasks to ask what is specific to writing and how is that different between healthy and dystonia. And what we found is that, in fact, what is specific is that there's a decrease in the connectivity between the left sensory motor cortex and the striatum in writer's cramp subject. And that is different from the tapping task, the extend task, and it is the only one that is different during the writing task in writer's cramp. So that suggested to us that the corticostriatal connectivity is an important region in dystonia. And this is work from my group, but this is actually consistent with what's known in the field from both preclinical mouse model studies as well as in human neuroimaging studies, that there is evidence that there is an abnormality in the corticostriatal circuitry in dystonia patients. And so that became the natural target for performing repetitive TMS stimulation to be able to see if we can modulate that deep brain region of the striatum. Now, I've shown you that we used fMRI to identify the abnormality in the brain network, but we also used the functional MRI signal to be able to make the connectivity and identify it as a region of targeting for TMS. The next question we asked is, TMS is not applied on the cortex, it's applied on the scalp, on the brain skull. And you have to worry about the fact that electrical stimulation can decay from going from the cortex, from going from the scalp and the skull all the way down to the cortex. And traditionally, the application of TMS, the orientation, the placement, the angle, all of that has been pretty much fixed for decades now. But we asked it in a more specifically biological way. What is the optimal orientation? What is the optimal placement of this coil that would allow us to maximize electrical delivery to the cortex and thereby the deep brain circuit? And so we decided to work with an engineering group, Dr. Ongo Peterchev's groups, that does electrical field modeling. And they do electrical field modeling to determine the placement of the TMS coil that would maximize the delivery of stimulation to the cortical sulcus. And so they developed this, fortunate for us, they developed this TMS and analysis pipeline called TAB. And what it includes is that we actually first identify, my team actually first identifies the functional cortical target. So we actually identify the premotor to putamen connectivity that was abnormal. And we actually use the structural T1 signal in combining with the group bold signal for that region, along with the individual subject signal to identify the specific region that we would target in each subject. So it was a customized TMS targeting plan. We then delivered this information to our colleagues, Dr. Peterchev's group, and they actually superimposed the functional target signal with the subject's brain skull that was actually reformed from images from MRI. And then they actually simulated the optimal TMS coil position that would allow the maximum electricity to within the cortex. And we knew that we had to angle it in such a way that was perpendicular to the gyrus to maximize the delivery of electricity into the cortical sulcus. And then lastly, they actually then added the electrical field modeling to determine what is the maximum electricity and what is the best placement to be able to maximize the electrical delivery. And then they deliver to us the actual information about the delivery of the electrical stimulation. And we are able to input this in our neuronavigation software to be able to perform the TMS stimulation with high degree of accuracy. And so this is their TMS analysis pipeline that includes MRI, both MRI and functional MRI. And then they're able to run computational electrical field modeling to be able to determine the optimal orientation, angles, and placements. Now, this is a prospective targeting pipeline where we're actually asking what is the optimal way to target, but then there's also the retrospective. We actually collect information during the TMS procedure that allows us to ask how much do we deviate from our targeted plan? And so in a way, we're kind of doing a closed loop where we're asking how well do we do in performing the TMS and how reproducible and accurate is it ultimately? And so the first thing we actually wanted to do was evaluate that. And so in our original design, we were planning to perform TMS in subjects, in writer's cramp dystonia subjects. So we actually had them come in for 3 visits. The specific visits were actually each visit of TMS in visits 3, 4, and 5 were a week apart, and each was a different condition. So we had subjects complete a TMS that was a sham TMS where they did not receive any active stimulation. There was active TMS delivered at the premotor cortex, and there was active TMS delivered at the primary sensory cortex. This was based on prior literature that there's actually 2 different locations in the cortex that could modulate the deep striatal region. And we actually were able to do this in a pilot group of subjects. So this was a double blind, both the subject and the person performing the TMS and our analysis team were blinded to the specific group. It was, in this case, really intended to be a single arm. We had one healthy subject as a pilot to make sure things were going okay initially. And it was crossover because all subjects were actually performing the study. So the first question we asked is, how well do we do in our targeting with TMS? And so we took the data from the neuronavigation software of movement of the coil itself and asked how much do we deviate, and then ultimately how much electricity do we provide to the cortical region. So this is actually data from Dr. Peter Trev's lab. And what we're looking at are these graphs that are showing different measures of coil deviations. And so we have 3 groups here. We have the sham, the premotor cortex, and the primary sensory cortex. And the TMS was delivered in 4 blocks of stimulation, alternated by blocks of writing. And what we actually did is we looked at measures of coil placement. So this is how much do we deviate from our intended location. And we're in millimeters, which is very, very low deviation. Similarly, we also looked at rotational deviation. And then ultimately, how much electrical field did we deliver? And is there any technical differences between the 3 groups? And the answer is, other than the sham, which we expect not to have delivered any electricity, we did not see any differences between the 2 groups. And so this is what our ultimate target looks like in image C here. And so now that we know that we had minimal deviation using this TAP method to deliver TMS, what did we see in terms of changes in deep brain regions, specifically the striatal region? And so we did this functional MRI immediately after TMS, and we asked how does it change the striatal activity, the transients 1 session of TMS, how does it change the striatal activity? So what we're looking at here is a blue curve, which is the premotor TMS applied at the premotor cortex compared to TMS at the primary sensory and sham. And we were measuring TMS across 30 blocks. Each block was about 40 seconds here with 20 seconds of writing and 20 seconds of rest. And we actually were looking at the deep brain. So this is a region of interest analysis where we looked at the striatal activity, striatal bulb activity. And what we see is that initially, they're starting at the same time point. And what we see is that as the subjects continue to write, we actually start to see a difference. in the striatal bold activity at the premotor cortex, where there's a transient increase in bold activity at the putamen when TMS is applied at the premotor cortex compared to primary sensory and sham. So we decided to focus on this specific subset of regions, subset of times where we're starting to see transient signal, and look at it across the 45 minutes of TMS. Now, if TMS was a one single session and it's a transient event, we should see an increase, a transient peak, and then a decline. And in fact, that is what we actually saw, that across the 45 minutes of the fMRI performance, we were able to see that the premotor cortex activity, that subjects who completed active TMS at the premotor cortex actually saw a transient increase and peak of bold activity at the putamen, and then a subsequent decline. And so that suggests to us that, in fact, repetitive TMS can transiently increase striatal bold activity in dystonia patients. And so in summary, what I have shown you today is that basal ganglia, actually, from our research as well as from prior work, is suggesting that the basal ganglia is playing an important role in the dystonia pathophysiology. That repetitive TMS at the cortex can actually non-invasively modify striatal bold activity. And this new method that we have developed in working in collaboration with our colleagues in engineering, called the TAP method, can improve the accuracy and reproducibility of the TMS stimulation delivery. And so overall, what this suggests is that TMS is actually a really powerful approach. It's a non-invasive approach. It's an approach that could modulate deep brain circuitry in a selective way, and that it could open up the opportunities for patients with movement disorders that were not previously accessible to them. And so with that, we're going to turn our, briefly thank everyone for their hard work. We've very fortunate here at Duke to have such a rich group of faculty to collaborate with, including your imaging expert in engineering, as well as our colleagues here in neurology, Dr. Michael Lutz, who's been working with me on the behavioral side of things. And with that, I'm going to actually turn it over to Bryan Howell.
Okay. Hello, everyone. Coming over from BME. Thanks for that great talk, Noreen. Can everyone see my slides at the moment?
Yes, we can.
Yes. Okay. Thank you. All right. So as I said, I come over from BME. I'm an engineer. I'm a research assistant professor. I work closely with Cameron McIntyre. A large portion of my work is actually looking at invasive therapies for treating depression and Parkinson's. But over the last 2 years, I've started to develop, as a biophysicist and engineer, an interest in looking at non-invasive therapies as well for treating these same disorder and diseases. When I met Noreen, I think it was about 2 months ago, she invited us to give a talk, and I seized the opportunity to talk a bit more about Parkinson's and how, as an engineer, I see the future of development of non-invasive neuromodulatory technology. So I'm going to keep this talk a little bit more focused on Parkinson's. That's an area that I'm more familiar with. And the idea here is, by the end, to have an understanding of where we are today in the development of a potential home-based therapy for treating PD. So as this is a forward-looking talk, I thought it would be appropriate to start off with some successes that there are already today. So you may be wondering if there are any potential devices in the pipeline that could serve as a home-based treatment for PD. As of today, the answer is no, but there are some that are highly promising. And one that I wanted to highlight was the Kala Trio, which is a wearable that's been developed by a company by the name of Kala Health. And what this is essentially a TENS device that has been transformed into a wearable. And what's added on board in this wearable is an accelerometer and some hardware and firmware to record and sense tremor, and then deliver pulsatile stimulation to reduce the severity of tremor. In this case, it's essential tremor. So what this wearable is used for, it's used for action tremor, and it's now currently 510(k) approved for treatment in moderately severe essential tremor, but it's now in the pipeline for treating active tremor and PD. So, be looking out for this one. But today I'll be talking about another technology. You know, if you can stimulate peripheral nerves and have the ability to have that activity propagate into the central nervous system, extinguish pathological activity somewhere in the thalamus and the cortex, there are other means of doing this non-invasively, and one of those means is transcranial electrical stimulation. So what I'd like to go over are, I'd say, 3 general kind of points by the end. One is I want to give everyone a better understanding of what this technology is, how it operates. Number 2, to give you an idea of how we think this technology is working, what are potential mechanisms of action, and finally give a summary of the current clinical evidence in using TES to treat Parkinson's. Now, Noreen already gave a great overview of some of the movement disorders, so I won't focus too much on this, but for those of you who are not neurologists and not familiar with Parkinson's, briefly, Parkinson's is a neurodegenerative disorder characterized by 4 cardinal features. You have tremor, rigidity, akinesia, and postural instability. In the earlier stages of Parkinson's, we know that there is a region in the midbrain that begins to degenerate over time. And as this region begins to degenerate, you have dysregulation in a collection of nuclei known as the basal ganglia. So when this dysregulation begins to occur, you have the emergence of pathological oscillations between different nodes in this network. Without going into too much detail, some of the signatures of these symptoms I've shown here. So we'll talk a bit about theta. These are oscillations that occur in this basal ganglia network between 4 and 10 hertz, and these are believed to be correlated with tremor. We have beta, which is a highly studied set of oscillations. These are between 13 and 35 hertz. They're primarily believed to be akinetic, or a signature of an akinetic state. And although we won't talk about high gamma as much, it's worth mentioning that high gamma is also present in the network here, and oscillations between 60 and 90 hertz can be either a prokinetic or indicative of a hyperkinetic state. So the strategy for TES is to try to modulate or extinguish this cortical or the oscillatory activity, but at the cortical level. So I'll give you an overview of the technology of TES and how it interfaces with the brain. Okay. So transcranial electrical stimulation, the general term is TES, but you may be more familiar with its specific implementations. There are a number of acronyms that are used with this technology, and the only difference between these acronyms is really in the shape of the waveform. If you're delivering current across the head and it's constant and either positive or negative, this is referred to TDCS. If the current oscillates over time, like a traditional sinusoid, this is termed TACS. We won't be talking about TPCS, but this is more similar to DBS. You can turn the current on and off in a pulsatile manner. This is a TPCS. And then if the current varies randomly in frequency and in amplitude, this is referred to TRNS. And so in comparing this to invasive stimulation, a good question to ask, and what most people are curious, is if you pass a current across the head, how strong are the fields generated in the brain compared to something we're more familiar with? For example, invasive stimulation. So if you were to put an electrode into the brain, whether it's a microelectrode or macroelectrode, you can generate a field that's on the order of 100 to 1,000 volt per meter. Now, this is enough to generate an action potential. So you can think of a pulse arriving and an action potential being generated in a volume of tissue. Now, if you move down to TMS, TMS is about a tenth of the strength of invasive stimulation. So you have a combination of the ability to be able to directly evoke action potentials, but there's also indirect effects. And then there's TES. And TES is the weakest of the 3. It's weak by a factor of 100. So it's 100th the strength of an invasive stimulus, which invites, the next question. If you're generating an electric field that is 1/100th the size of what you do when you stimulate, let's say with DBS, can you do anything? And the answer is yes. So the weak fields produced by non-invasive brain stimulation can actually influence neural firing, but it's an indirect effect. So I've shown here a simulation from a previous project where we're looking at developing new strategies for TES to illustrate how this works. In this study, we put together Models of pyramidal neurons is a cartoon representation of that. So you have the somal compartment and the dendrite compartment, and these can be injected with a noise-like waveform to emulate synaptic activity. And you can see that this neuron here fires endogenously in a somewhat random manner. If you then apply a positive current at the surface of the scalp, you have an electric field that's pointing inward, and the firing rate increases. And if you reverse the polarity, you decrease the firing rate. So you're not actually entraining the neuron. What you're doing, if you look over here at the left, is you're changing the baseline membrane polarization so that if there is noisy activity happening or synaptic activity, you're more likely to have an event happen. So the mechanisms of action of TES are still being investigated today. There are a lot of different ways we think it's working. The two ways that are well established are in inducing plasticity and in facilitating rhythm resonance. If you recall back, there are a number of acronyms. If you apply TDCAS in hippocampal slices with a plasticity inducing protocol, without the TDCS applied, you have baseline level of plasticity that happens that you can induce by stimulating, in this case, with Schaefer collaterals with microstimulation. And if you apply an anotic TDCS, you can increase the amount of long-term plasticity that's observed. If you flip the polarity, it's the opposite direction. Recently, there's also been another study done in macaques as further proof that these weak electric fields can actually modulate neural activity. Here you see a single unit recording over time split into epochs. So as you go from top to bottom, you see this same neuron as it's firing every 200 milliseconds. And the orange is indicating when the TACS, so now we're talking about alternating current, when the TACS stimulus is on and it's increasing in dose from 0.5 milliamps to 1.5. And so you can see here that if you look here at these alignment plots, or you could simply see with the rasters here, is that this activity is increasing some, but also coordinating with respect to the swings of the AC stimulus. That gives you an idea of the technology and how we think it's working, at least with direct threshold modulatory effects. Now I'd like to move on and give you an overview of the current evidence of using TDCS and TACS for treating symptoms of Parkinson's. This is a growing field, so there are not a large number of studies, but there are some, and I'll start with those that came out of the Peter Brown group over in Oxford 2013. The idea here was to get at tremor suppression. And if you recall from one of the earlier slides, we know that theta activity in the cortex is correlated with tremor. So the strategy here was to record this theta activity indirectly by using an accelerometer as a subject sat on a chair. They would record the accelerometer and get an idea of the oscillating tremor, which I've shown here in green as an annotation. And what this control system was trying to do when they delivered TACS, they delivered this with a pair of electrodes where the anode was sitting over the primary motor cortex. They aligned the stimulus such that it was anti-phase with the tremor, with the idea that if you are positive when the tremor is negative, that you would be extinguishing some of the theta activity in the cortex when the stimulator is on. And in the study, they had a fairly dramatic decrease in tremor. You can see that here in the middle. Tremor went from baseline down with a decrease of almost 40% across the subjects. Another approach taken by Krauss was to look at the treatment in a different way. If beta is kind of not only correlated but causal with producing rigidity and akinesia, their hypothesis was that if they injected a TACS protocol at 20 hertz, this would be a beta protocol in the primary motor cortex, they would cause retardation and slowing of movement. So they had a finger tapping task here. And this finding was counterintuitive. So you had healthy controls and Parkinsonians and individuals, and they were executing a finger tapping task. What actually happened when they injected beta into the primary motor cortex is it helped regularize the finger tapping. It didn't get faster or slower, but it became more regular. And then finally, we have a study by Del Felice more recently, which was a more personalized approach. And here they used EEG to localize areas near the primary motor cortex where you had a predominant amount of oscillatory activity. And if they recorded theta, which I've shown an example or an illustration here in green, they would stimulate at a beta frequency. And if they recorded a lot of beta activity, they would switch and stimulate with theta. So the idea here was that if the network was in a pathological state, you wanted to get it out of that state by stimulating with another frequency band, aside from the one that's being exhibited while at rest. Here they did this only once. It shows you here at baseline, the UPDRS score. And then this is the T1 is after one treatment, and T2, they were looking at carryover effects 2 weeks later. So the conclusion here was that, yes, it did have an effect. It was personalized, but the effect was fairly small overall. Now, there have also been studies on TDCS for Parkinson's, specifically looking at improvement of gait. There are a large number of these. So I won't go through each one individually, but there are now meta-analyses looking at overall over the, let's say, the 10 plus studies that have been conducted to date. What is the consensus whether TDS can help with improvement in gait? And the answer right now, if you normalize it, is that it has a small to negligible effect. But I have a different interpretation of these results. I think if you look at it, there's a danger in averaging across this number of heterogeneous studies. So something to point out here that if you apply a TDCS, but you're doing it over multiple electrode locations, there may be a pattern here and having greater success. Another thing I noticed across these studies, especially in the middle ones here, is that one of the primary targets they chose was the dorsolateral prefrontal cortex. And this is based on the theory that with Parkinson's, you're losing your ability to execute motor control in an automatic manner. And so there is a compensatory mechanism that you can facilitate by targeting the DLPFC. So at this point, there aren't a lot of clear kind of directions. We see that TDCS and TACS can have an effect on improving some of the symptoms of PD, but we see that the delivery of the stimulation is far from optimal. There are a number of questions that are left unaddressed from all of these studies, which I've summarized here. For example, it's not known when we should be administering the stimulus or the protocols, whether it should be before, during, or after physical therapy, whether it should be delivered on or off medication. And to highlight another example, we still don't know from the TDCS studies where we should be targeting. It may be that the optimal way to treat PD with TES is through multi-target stimulation, but there may be, there is evidence to suggest that the prefrontal cortex may hold a lot of weight in delivering modulatory effect. So I'll go ahead and go through this last part quickly to stay within time. Now, as an engineer, I think about the technical challenges. So with these studies, there is heterogeneity in the patient populations and heterogeneity in the approach. But one of the questions that or potential issues that can explain some of this variability is whether or not when you're administering TS, whether you are adequately dosing. So if you remember in some of the earlier slides, we know that TS produces weak electric fields. And from animal studies, we know that you need to be around 1 volt per meter to have a modulatory effect. But now we're seeing from postmortem studies and other studies that use simulations and TMS to predict, how much current is actually being delivered to the target region. The doses that are used in these studies are about 3 or 2-fold less than what would be needed to actually achieve the critical field strength of 1 volt per meter. And then finally, I'll close by saying that, in terms of thinking of a home-based therapy for PD, the the delivery is far from optimal, but as engineers, we also think about translating this technology in something that can actually be taken home. Now, at the current state, if you were to give a subject a pair of electrodes and have them place them themselves and administer the therapy, that would be very difficult to do. So as engineers, we should think of ways in translating all this technology into a wearable that can automate the delivery of this treatment, potentially through a cloud-based solution where you could connect with a neurologist to help you program the first or second time and set up the stimulation, and then you could use it henceforth on your own with the click of a button, similar to the Kala Trio. So my closing thoughts are that as it currently stands, the effects of TES on PD are too small and too variable to move forward with the development of an actual prototype. It may be due to inadequate dosing. This is an area where I'm actively working in myself and thinking of ways to deliver higher doses that would be tolerable so that you can stimulate at 4 milliamps, 8 milliamps, or 10 milliamps, and it's not inducing overt side effects. I think that TES could potentially be, as it stands, an augment for physical therapy. But I do think that there is, promise for a telemonitored TES solution for treating non-motor symptoms of PD, as there is a quite amount of literature and evidence that TES can be used for treating depression. And you're now, excuse me, seeing studies emerging where they're treating non-motor symptoms of PD successfully at home with these telemonitored solutions. And with that, I'll go ahead and take any additional questions. Thank you for your time.
Thank you both. Anyone with a question can put it in the chat. And I'll start off. Noreen and Bryan. So one thing I've always been struck by, I've been told, I don't know this, that when you have DBS electrodes in for Parkinson's disease or tremor, and you just blast away at high frequency for 5 years, and then you turn them off, those neurons are spiking at the exact same rate they were 5 years ago. If that's really the case, what hope is there for making some long-term change in neuronal spiking using transcranial approaches?
Yeah, that's a great question. So I think, part of that is really understanding where are we in the circuitry, right? So deep brain stimulation is pretty downstream in the overall circuitry of movement disorders. So we have the cortex, and then we have the striatal, the thalamus, the pallidum. So, I think that DBS is farther down than where the pathology is. Obviously, this is my perspective. So I think, if we target at where the pathology is in the circuitry, then we're better in a better position to allow for long-lasting therapy. And I think if you go downstream of the area, then you're less likely to see that. And so that's where my feelings are. Certainly, I think.
And it may be that the where you're stimulating the basal ganglia is so end stage that there's no chance to get any plasticity there.
That's definitely true. DBS is an option later in the disease process. And certainly if, especially in Parkinson's, if things have degenerated, it makes it more difficult to get that more disease modifying kind of effect or long lasting effect. So I think certainly the course of the disease, where we are in that, will definitely have an important contribution to it. But I think also not thinking about it in a system network way, and where we are in that network and where the problem is, can also have some important implications for the long-term effect of the therapy.
Is that your actual room, Noreen, or is that a background? It's very pretty.
I get asked about that at least once every few weeks. Yes, that's not my home. It's nice Zen environment. So no, that's not my home. It's just a Zoom background.
All right, Dr. Feng has a question.
Well, good job, and Noreen and Bryan. But my question is meant to Bryan. I'm very excited you actually work on PAES. My lab actually in the last 8-9 years actually also work on TDCS and stroke motor recovery. A lot of issues you highlighted for the Parkinson's disease exactly existed for for post-stroke motor recovery. Same as you, we actually also believe there's underdosing issues. We actually spent quite a bit of time look at the animal data, simulation models, and also did in vitro measurements in patients with Parkinson's disease. If a fatigue is on, he's running actually funding actually look at collect data, do in vivo measurements, and in patients with persistent drug-resistant epilepsy, they'll place SEEG, so you have a good sampling of those data. But they are emerging data. Mary Bickerson's group, and last night was quite a bit on the call with a group and overseas group. But there's a lot of data suggesting the measured electric field data is pretty equivalent to the particular model use FEM model. So I certainly think those things issue. We actually advanced to 4 milliamp. I think potential could be go more, but we have to work on the electro technology. You have to make sure we have to take care of the safety and tolerability issue to the skin. If we want to really advance the dose. At the same time, you cited quite a papers from Ganguri from UCSF. We had a quite a conversation. I think, like TMS, once the electric field goes to 100, volts per meters, so those maybe stimulation really strengthening cortical spinal connectivity was really non-invasive TACS or TDCS, maybe really example the co-firing of the neuron, not really and strengthen the cortical spinal tract. Maybe just two different way how we influence the neurons, how to induce behavior effect. But I agree, probably there's underdosing issues because all the current protocol with TES, they're all below than 1 millivolts per millimeters, because that's what I sort of kind of believe the minimum threshold need to influence the field potential, but now the model, but now the non-invasive technique actually are there. Most of them like only about 25% or 30%.
Yeah, those are all great points, and I'll add a couple of comments myself. In terms of reaching this critical level, it's commonly accepted now that, with TS, because of how weak it is, has to be paired with certain activities. So in itself, even if you do have 1 volt per meter, the ability to induce plasticity is still fairly limited. In the slice studies I showed you, in fact, it may not be obvious, but if you read that, they were applying a 20 volt per meter electric field. So the dosing is 20 times higher. So in some of these animal studies, it doesn't translate well to the humans. But as to your point as to increasing the dose, I do have a few things to say as an engineer. That I think that depending on the waveform, we have this standard limit of 2 milliamps, but it really depends on which waveform you're using and the parameters of that waveform. For TDCS, it was surprising that you can double the dose. There's a study from the Bixen group that came out, and there was no discernible increase in discomfort. And what I think is happening there is that there is conduction block occurring above 2 milliamps. So as you are activating nociceptive fibers that cause the discomfort, at the same time, you're also inhibiting the proprioceptive and pressure sensing fibers, the A beta fibers, as you increase the stimulus. So that could potentially explain why TDCS has a higher dosing limit. And then in regards to TACS, there is a frequency or rate dependent response. So the ability to get up to 8 and 10 milliamps is really going to be dependent on kind of leveraging the low and the low pass filtering properties of the neurons and the filtering properties of the tissues and the nerves. So I do think higher limits are possible. So in individuals that aren't getting adequate doses at 2, you could, by delivering different waveforms, you could potentially stimulate at 4 and 6 milliamps and have no more discomfort than a conventional protocol.
No, I agree. Yeah, those are great point. Yeah.
So I'm going to throw it to Jeff for the last point, but I would like to say, we have so many people now in the department and the institution doing these studies through movement, stroke, memory with Simon. I hope you folks are talking to each other and like maybe getting together every now and then. And
Rich, that's actually a great point. Actually, there's critical mass in neuromodulations.
Really is.
Yeah, last year, I actually took it sort of kind of and a leadership sort of put it together as center grants, but unfortunately we didn't get funded. But through the efforts, we really know a lot of
I'll pay
folks.
for a pizza if you guys folks want to get together.
Yeah.
Yeah. But Noreen, I think it's really important.
Yeah, no, it is important. We actually do have Kyle Mitchell is actually leading a quarterly meeting among the DBS and really bringing together a multidisciplinary team of neuromodulation group.
Including the stroke and Simon. Good,
Yep.
good. Yeah.
That the plan is to bring invite everyone to that group. So
If you need food, we'll pay for it.
we will hold you to your word on that one. Food
Do
is
the
always welcome.
engineers come too?
Yes, definitely the engineers.
Oh,
Dr.
great. We
McIntyre's group
can't
is
get by
invited.
without them.
And Warren Gray actually
Other charge of 5 for the engineers.
yeah, and Warren Gray also runs the periodic kind of neuromodulation seminars. So there's a lot of activities actually ongoing this
That's
moment.
great. I mean, you folks all know I'm a skeptic, but if anyone's going to sort it out, all of you young people will. All right, Jeff, you get the final question, comment.
Oh, I was just responding to your comment earlier where you were asking about, with DBS looking like you can stimulate for years and then turn it off and then the firing is unchanged. I was saying that's gonna depend on the disease state. So some things like tremor do seem to have don't seem to have sort of a long-term neuromodulatory effect. Whereas if you look at the effects on dystonia, it doesn't seem like at least the clinical benefit doesn't show up instantaneously. It seems to be much more of a long-term effect. It may take weeks or even months to show up. So I think
then does the spiking rate seem to change when you turn the electrodes off?
I don't know if they've looked at the spiking rate per se. So I can't answer that specifically,
Marine
but
might know.
certainly the clinical benefits are delayed.
Yeah, that's an interesting point.
So it's sort of different. And I think that's probably a different circuit altogether in dystonia than in some of the other conditions.
Noreen, you want to comment on that?
It looks like Kyle has some comments actually.
Kyle, you want to pop up?
Is my microphone working?
Yep.
It was broken earlier. Oh yeah, I was just going to say that when you look at the pathological oscillations in dystonia, when you withdraw DBS, those oscillations remain suppressed on the order of hours, as opposed to immediately resuming.
Okay, well, that's something to start. All right, everybody, be safe. Great presentation, everyone. Great discussion.
Thank you.
Thanks.
For the invitation. Great talk, Noreen.
Yeah, thanks, Brian.